Okay, this is a 25-year-old gentleman who is now 2 weeks down the line following a penetrating injury to the anterior shoulder area. He presented with a vascular injury as well as neurological deficit. He was taken as an emergency to theatre, and hand surgery team was called. An end-to-end repair of the axillary subclavian artery was performed. So really what we want to do is focus on the examination. As I've said, when you get an injury to the infraclavicular plexus at this level, anywhere between the axilla and the clavicle, you should really look at it in terms of the nerves and then work backwards to try and identify the level of injury. So if we just start off with the radial nerve and the axillary nerve, so just lift up your wrist. So it's got a strong radial nerve. Lift up your fingers. Lift up hard. It's got strong finger extension, and lift up your thumb. And good thumb extension, as well as it's got intact deltoid, and make your arm straight. Make your arm straight. Push hard against me. So he's got a good tricep. So his whole radial nerve, which means going from distal to proximal, means the posterior cord is intact. So at this level, it's all about the cords, the M shape of the plexus around the axillary artery. Next, we'll look at the so I'm just going to draw on this patient. So you've got the lateral cord continues as the musculocutaneous nerve, and then it gives off the lateral limb of the median nerve. Then you get the medial cord, gives off the medial limb of the median nerve, and then continues as the ulnar nerve. So that's musculocutaneous nerve. This is the ulnar nerve, and then the medial limb and lateral limb of the median nerve continue as the median nerve. So what's in these different fibers? So musculocutaneous nerve is working, bender. So it's got very strong biceps. In the lateral limb of the median nerve is FCR and pronator teres. So you can see if this guy flexes his wrist, bend up your wrist like this, I can palpate. It's difficult to see. It's very strong FCU, no FCR, nothing. As well as he has no pronator teres. Keep your arm turned in, other way. There's no palpable pronator teres here. So that means there's no function in this. If we look at the medial cord, that continues as the ulnar nerve. So if we look at the ulnar nerve, the FCU is working, bend up like this. FCU is working, the ulnar nerve intrinsics are working, the long flexor to the little finger, bend this one, is working, and the ulnar nerve intrinsics are working. Lift up to the roof, push up hard. There's some weakness, but just lift up that way. There's some power, but there's definitely some weakness. So there's a little bit of injury to the medial cord / ulnar nerve. But what you can immediately see here really has got some trophic changes, some burns from damage to the radial side of the hand. So in this lateral limb of the median nerve also runs the sensory fibers C5 and C6 to the median nerve distribution. And then in the medial limb of the median nerve runs all the FBL, bend there, got no FBL, all the FDSs, and then the FDP to index and middle. So make a fist for me. You can see a typical high ulnar nerve, median nerve palsy with the benediction or the trigger sign or the shooting sign, and he's got no thenar muscles. Bring your thumb across. No palpable thenar muscles. So here we've got a high median nerve palsy with typical sensory distribution deficit, and the injury is therefore either at the level of the two limbs of the median nerve or the median nerve itself, or and a partial injury to the ulnar nerve. At the time of surgery, it was explored and was noted to be macroscopically intact. So presumably it's due to the false aneurysm that formed, or from retraction by the surgeons. Difficult to say, but there's no macroscopic injury that needed surgery. So the recovery is expectant. We already see an advancing Tinel sign. So if I tap him along the course of the median nerve, tell me when you get the shock. Yeah.
Yes.
About over there, he's already getting a Tinel sensation of a shock-like feeling extending into the median nerve distribution. Implies that there's continuity and early recovery. So this is probably a neuropraxia. It's not an axonomesis, otherwise it will take much longer to recover. Remember, an axonomesis still has to recover at 1 millimeter a day, whereas a neuropraxia recovers quickly. So this is a neuropraxia, and we expect a full recovery. So we don't really need to talk about the reconstruction. But this is a typical high median nerve palsy. Make a fist with the benediction or the pointing or the gun or the trigger sign. Okay.